Then we
Okay.
to,
Well, and I'll try to find more.
yeah, then we want to.
I have a friend who's, her family's big in chicken farming.
Mhm.
Apparently they use them too. So I'm gonna, chicken farmers in general. Have you ever been in a chicken house?
I've heard of the chicken dough.
Okay. All right.
Well,
You're recording? It should be good.
To start? You're being recorded now.
12:02.
Okay. So my name is Dr. Khalid Mohammad. I'm one of the pulmonary critical care personnel here at Jefferson Regional Medical Center. And as you all know that we are going through a pandemic brought by this SARS coronavirus 2, also known as the COVID-19. Now, the times are tough. And based on our experiences or the experiences that other people have had in countries like China and Italy, we do know that the healthcare delivery system is compromised very soon and very fast with this particular disease. Hence, we need to prepare in advance so that we should be able to mobilize our healthcare resources and personnel effectively and judiciously. In order to do that, we need information. And that's where I am here, because I would like to provide some information that pertains to the critical care management of the COVID-19 patients. So our work essentially starts the moment the patient comes to
Pretty good. Okay, start.
that's
Or we
very,
can do it here.
yeah.
Well, hang on.
Yeah, I think he's trying to hit that little arrow.
There we go.
Next slide, please.
Next slide, okay.
Okay, so our work essentially starts from the moment a suspected or a known COVID patient comes to the emergency department, and I'm being called to ask who to admit, who not to admit. So since the time we started seeing all these patients, there were three things that I actually looked at and tried to answer these three questions. And we've been pretty much successful in trying to triage these patients depending on the answers that I get to these three questions. The first thing that I always ask is the hemodynamic stability. Is the patient hemodynamically unstable or not? If the person is hemodynamically unstable, irrespective of their respiratory failure, they most likely would come and get admitted to the hospital. And when I say hemodynamic stability, what means is if, let's say, somebody is hypotensive, they get adequate volume resuscitation and their blood pressures improve, heart rate comes down, and we are comfortable stating that, it was essentially dehydration, then we don't really need to admit some patients like this. But let's say somebody is really looking sick, they are hypotensive, tachycardic, irrespective of whether they are in respiratory failure or not, they'll have to be admitted to the hospital. The second thing that I look at is acute respiratory failure, and acute respiratory failure in the presence of lung infiltrates and needing oxygen. If you have a combination of these three things, they will probably have to be admitted to the hospital. And the third thing is if there are some comorbidities that actually necessitate their admission. As an example, let's say a suspected COVID-19 patient comes to the hospital, hemodynamically stable, blood pressures and all are good, not in respiratory failure, but their sugars are uncontrolled, the diabetes is uncontrolled, or the blood pressure is uncontrolled, or they're having active chest pain. So they need to be admitted for these comorbidities rather than the COVID-19 suspicion by itself. Next slide, please. Okay, now when do you admit these patients to the ICU? Again, these are the four questions that I actually look at, okay? The first one would be the hemodynamic stability. Somebody on the floors, getting hypotensive, not responding to fluid resuscitation, there is a chance that he or she may need pressor requirements, then that person needs to come to the ICU. Worsening hypoxic respiratory failure. Now this particular terminology, worsening hypoxic respiratory failure, is very subjective as to like what would you consider as worse. Like if somebody is on, let's say on the floors on 7 liters oxygen through the nasal cannula, if they go up to 10 liters oxygen, are they considered to be worse or not? right now, we've been taking patients with increasing oxygen requirements to the ICU, but very soon we will be in a situation where we have to decide whether we are going to intubate this person or not. If this person would need to be placed on mechanical ventilatory support, they need to come to the intensive care unit. My experiences with the COVID patients have been that even when they have been requiring high oxygen, they have been relatively comfortable. You know, they do not usually behave like bacterial pneumonias with extensive infiltrates the way it is and requiring very high oxygen in them. They are actually much sicker than these patients. So as a result, this is a very subjective thing, and we have to use our discretion in deciding who comes to the ICU or who doesn't come to the ICU. Third thing, again, comorbidities. You have a COVID patient, suspected or known COVID patient. Let's say he develops an acute MI on the floors. Clearly, they need to come to the ICU. Or they are in DKA. They need to come to the ICU for that. Now, the last thing, and it's a very, very important thing, we have to weigh all the options available with us. When we say we have to weigh all the options, that means it's a very important thing to look at the patient in totality. Okay, I'll give you an example. The other day, I was called to admit a patient to the ICU, and that person had metastatic breast cancer, stage 4 breast cancer, and as per the oncologist, not much treatment options were available. So those are the times when we have to have a very good discussion with the patient, along with the oncologist, to see if really that is something that we need to do in these patients, like bring them to the ICU, intubate them, because a lot of times if we have a good conversation, they may want to be DNR, and we can actually avoid putting a stress on all our resources in the ICU. So the fourth step is very, very important, and I think we need to do this very judiciously as time goes by. Next slide, please. Now, the person in the ICU, what do we do now? Of course, this patient is on strict isolation precautions. We assume that they are on the floors. If not, we are thinking about it. They got to have very strict isolation precautions. And isolation means droplet, contact, airborne, all three of them. En route also, we should try utmost to maintain that isolation till the time the person comes to the ICU. They reach the ICU, we should do the reason for which they were brought to the ICU, which is to correct the hypoxia. We provide them with supplemental oxygen. Now, there's been a lot of talk about high frequency, high flow oxygen nasal cannula and the aerosol generation. Because of which, because if you're using very high flow oxygen, there's always a chance of some aerosol generation with them and putting other people at risk and causing more virus transmission. So as a result, what I usually like to do is to use combination oxygen devices, like use a face mask and a nasal cannula both together. That will limit the amount of, first of all, the face mask will prevent the aerosols from escaping out. And the second thing is the amount of high flow nasal cannula oxygen that you would need would be much lesser. We should try to do that and try to delay intubation as much as possible. I'll tell you why, why we should try and delay the intubation a little later. Now, we should try and avoid all kinds of CPAP, BiPAP, non-invasive mechanical ventilation, because there is a lot of air leak that's happening. We don't want everybody to be exposed to all the air leak, and there is a potential that there could be a lot of aerosols in that air leak. So as much as possible, unless we have a closed circuit, there is no way that we should be using the CPAP or the BiPAP in these patients. Okay. Also, things needed to be avoided are nebulizers, chest compressions, chest percussions, again, because of the aerosol generation risk. No bronchoscopy unless intubated. And this goes actually for all the procedures in COVID patients. Unless there is a procedure that really dramatically changes the way we manage these patients, we should completely avoid any invasive procedures. We do not want to have complications, because all of them are replete with complications. That's number one. And number two is we would like to limit our exposure to the COVID patients as much as possible. Next slide, please. Now, the person is in the ICU, oxygen has been provided, blood pressures and all of those things we have already looked at. And what do you do next? So the next we need to give them, there's some data. I mean, we don't have a very robust data on the medications that are required to treat them, but then there's some data on hydroxychloroquine. Easily available, cheap, not much of side effect profile. So I have been using the hydroxychloroquine in all the patients that I'm suspecting or proven to be having COVID. And there are different dosages that are available. The dose most commonly that I saw was 400 milligrams BID on day 1, and this was followed by 200 milligrams Q8 hours for anywhere from 7 to 10 days, and depending on how the patient actually responds in the course of time. Always draw blood cultures, sputum cultures, urine cultures if it has not been done yet, and do start all of them on empiric broad spectrum antibiotics, because a lot of them actually harbor secondary bacterial infections also. We cannot be short-sighted and just think about COVID and leave the other thing, because more likely than not, they will have a bacterial infection also along with the COVID-19 infection too. Okay, so we have to treat infections like the regular infections that we see. DVT GI prophylaxis has to be on board. Okay, and no NSAIDs, only Tylenol. Okay, and be judicious when we are using Tylenol. The other day I saw a Tylenol continuous orders, like to use it even without any fevers or anything was there. We unnecessarily are putting the patient at risk of some liver involvement. We should try and avoid that. Only when the fever goes beyond 101, we should try and use Tylenol in those patients. Next slide, please. Now, when do you intubate these patients? Okay, this is also the first thing that we should look at is the clinical judgment. What does the treating physician think about the patient? Does the treating physician think that in his clinical judgment at the bedside, that person needs to be intubated? None of the absolute criteria should surpass that. Okay, that's very, very important. Now, some objective things that we look at is worsening hypoxia. When I say worsening hypoxia, we have used all the supplemental oxygen devices in them, and persistently their saturation, SpO2, keeps falling less than 88%. That's one of those justifications to intubate these patients. Secondly, mental status changes, and there is a concern that the patient would not be able to protect their airways. Again, those are the times to think about intubating those patients. Now, let's say the person has been on supplemental oxygen for the last couple of days. They have been doing fine, but then on ABGs, which we are not doing it as much as we should be doing, okay, in these patients, we see that the PCO2 is climbing up and the pH is starting to fall down. What that means is that person is tiring out, and very soon we'll have a bad outcome, meaning that they can have a cardiac arrest, but God forbid it happens in the middle of the night. Okay, so those are the patients that preemptively we decide that, okay, now is the time to intubate them and start mechanical ventilatory support. Again, hemodynamic stability plays a very, very important role. You have none of these things, but a really hemodynamically unstable patient will get intubated for that. Okay, and what I have tried to do is always get anesthesia involved in these intubations, because howsoever smart you may be, howsoever skilled you may be, always ask the specialists to do this, because you would like to prevent more aerosols from being generated during your efforts to intubate somebody, which of course there's a lot of aerosol generation, bagging the patient, paralyzing them and all that stuff. And you want to do these procedures in one try. Okay, you don't want to have too many attempts doing it and expose yourself and the staff, because there is a staff in the patient's room helping you out. Okay, so always please ask the CRNAs or the anesthesia attending to come and help you out with the intubation in these patients. Now, we talked about like why we don't want an early intubation. What I have seen is these patients have a lot of sympathetic overactivity. Because of that, their hemodynamics have been maintained till the time their oxygen supplementation is going on, and they're alert mentally, and they have their own drive, respiratory drive. Once you intubate them, the sympathetic drive is cut short and they start to get hypotensive. And then on top of it, you have to use sedation as well. Okay, that causes more hypotension. Hypotension demands you to be present at the bedside more often than not. Okay, a lot of complications comes through after that, and you end up dealing with 2-3 different things, where in the beginning you were just with one particular problem, which was the respiratory failure that you were dealing with, okay? So be very, very judicious in when to decide to intubate the patients. Hopefully, these particular criteria, some of them may help you decide when to go for the intubation, okay? Now, the person is intubated, all secured. What do you do with the ventilator, okay? None of us are expert in managing the ventilators, okay? And when we are talking about the hospitalists, the GI doctors, the pain specialists, and all of them, if they are asked to, let's say, manage the ventilator, the basics of it, I think this will prove very helpful. First and foremost, always talk to the respiratory therapist. All of them are of great help, very knowledgeable, and they will guide you thoroughly, okay? So they know what they are doing. So they would be the best resource. Nothing that I can tell now will surpass what they are telling you, because they have been doing it for quite some time. They know the drill, okay? So that's number one. Number two is there are tons of modes, different types available there. The monitor, it's like a computer, and lots of stuff over there, lots of numbers and stuff. But I think in order to simplify everything, most important thing is always pick the assist control mode of ventilation. That's the basic.
Can I have your attention, please? With Narissa and transport, please call switchboard. Narissa and transport, please call switchboard.
If you choose the assist control, volume control mode of ventilation, any disease can be very effectively managed, and including the ARDS brought by this COVID-19 can be very effectively managed by the assist control, volume control mode of ventilation, okay? Now, we have selected this. What are the parameters that we need to select? There are only 4 parameters that need to be selected and put by the treating physician. The rest, everything is inbuilt, okay? And it's on the default setting. We don't have to mess around with them at all, okay? And what are those? The tidal volume. Rule of thumb, very important, this particular one. 6 to 8 mils per kg predicted body weight. Google predicted body weight, put the height, it'll give you the weight, okay? And then multiply it by 6 to 8, whatever number comes through, you put that as the tidal volume, okay? That's very simple. Now, the respiratory rate can range anywhere from 16 to 35. It all depends case by case, depending on for what are you treating, how bad is the ARDS, depending on that, okay? Both of these parameters will decide what is the pH and what is the PCO2 that the patients are going to have, okay? So it'll be very simple if you go by this particular way. And this is what the ARDS net also, you know, the big trial, that's what they actually ask us to do. How to set the FiO2? Always start at 100%, okay? And start dialing down by 5% every 1 to 2 hours, okay? And the goal should be to keep the saturation 91 to 93. We don't want a 98. We don't want a 95. We want it 91 to 93. Whatever oxygen would be required to get to that, we dial it down and we get there. Very important that you communicate all of these things to the respiratory therapist. The respiratory therapist is not going to do anything by themselves unless you communicate in very plain, simple words, or put down an order like that wean accordingly the way it is, okay? And PEEP, this is the positive end expiratory pressure. We all have some basic idea of that, but not going into the details of all of these things, because you know it will be very complicated and difficult to understand. The goal is to keep the PEEP anywhere from 5 to 12, depending on how well you are able to oxygenate somebody. Some patients may need higher than that, but then if anybody needs more than 5 to 12, you need to call for help at that point of time. That means that that person is very, very sick, and they need more than what somebody else can do it. They need a trained person who can handle all of that stuff, okay? So 5 to 12, nothing beyond that. Again, I'm always trying to limit the PEEP in these patients. Again, for reasons very, very obvious. You keep a high PEEP, you invite complications. And those complications, again, risk of aerosol generation. They will develop a pneumothorax, and the pneumothorax will happen suddenly. Everybody will have to rush because the person is on so much oxygen and everything. There's always a chance of break in your PPE protection, and you may have to place a chest tube. The chest tube, again, invites lots of aerosol generation and leak, so you try and limit that. COVID ARDS is a little bit different that I've seen from ARDS due to, let's say, a bacterial pneumonia or let's say shock or a trauma. Those patients are actually much difficult to oxygenate and ventilate than the COVID patients. Most of the time, you are actually able to oxygenate them relatively easily. Ventilation usually is never a problem. When I say ventilation, it is management of the carbon dioxide. Ventilation has not been a problem. And they are not requiring a whole very high PEEPs as such. If you stay within this 5 to 12 range, usually they have done relatively well. Okay, next slide, please. Now, there's lots of pressures on the monitor that you see of the ventilator, lots of numbers. All of them don't mean much. What really matters in this particular subset of patients is only one pressure that I would like to mention, and that is very important that everybody is aware of that. It's called the plateau pressure, okay? And what is the plateau pressure? Without going into the details of how we calculate the plateau pressure and everything, very important thing, there is a particular place on the ventilator screen and it is called the inspiratory hold. Just press that for 10 seconds and it will give you a number. That's the plateau pressure. That's the one that actually determines the mortality in ARDS patients. If you're able to keep the plateau pressure less than 30 at all times, the mortality is actually 10% lower than if you keep it higher than 30%, 30 of the plateau pressure. And an RT can help you with all of these things. They know all of this, how to know the plateau pressure. So if for some reason you're not able to get it, please do talk to them. They will help you with it, okay? And let's say the plateau pressure is more than 30, then you reduce the tidal volume. Reduce it by 1 mils per kilogram body weight and reduce it to as low you can go to 4 mils per kilogram body weight, okay? If you do all of these things, the tidal volumes are coming down. So what's going to happen? The pH is going to go up because there is more carbon dioxide that is being generated, okay, and not being washed out. So what do you do in these situations? The knee-jerk reaction is to go up and get a very good number on the ABG, but that's not actually going to save lives. That's actually going to be detrimental. So there is a concept called permissive hypercapnia, and you actually let the pH be low, okay? As long as it is more than 7.2, you're actually good, okay? So no need to actually have right in the box of a 7.35 to 7.45 pH. That's not what it's advocated, okay? Next slide, please. Now, the person is on the ventilator. Now, how do I sedate my patient? Okay, very important question. Now, we always should try to use analgesia first. When I see analgesia, it's pain control. A lot of times, just controlling the pain is all that is needed, and the patients are very comfortable with that, okay? And you start with using as-needed fentanyl, or you can use some morphine also, but morphine usually drops the blood pressure. Fentanyl doesn't do that as much. Start at like 50 to 100 micrograms sequentially and see if you're able to get this RASS target of 0 to -1. Now this RASS, what is this? This is just a sedation score. The nursing staff is all well versed with it. You just need to put down an order of the RASS. RASS of 0 to -1, meaning calm and comfortable to lightly sedated. That's all that you need to do. You need to no need to go into deeper aspects of this thing, okay? If analgesia is enough, patient is comfortable, you are able to achieve this RASS, fine, we keep doing this, okay? Let's say even after doing this, because every so often you will find somebody not getting sedated enough on the fentanyl, then go for anesthetics like Versed, use it at 1 to 3 milligrams per kilogram body weight. If PRN is not enough, 1 to 3 milligrams actually, not per kilogram body weight. If PRN is not enough, then you can start a drip. And do not fret much over the dose. Pharmacy knows all about it. You just have to pick up the phone and ask the pharmacy. They'll do everything for you, okay? And then you titrate accordingly. The other alternatives are propofol and Precedex. I usually like to avoid them in this because once a COVID patient with ARDS gets intubated, you're looking at a couple of weeks on the ventilator, okay? You don't want to use propofol for more than 48 to 72 hours, okay, because of different reasons. And also be mindful of hypotension with all the sedation, especially with the propofol and the Precedex, okay? And always put down the order of daily sedation vacation. But we have to use it with a pinch of salt in the sense that, let's say you have a COVID patient in ARDS with a lot of oxygen requirements of PEEP. You don't want to wake them up daily, okay? Because if you wake them up, there will be patient ventilator asynchrony, okay? And you can get hypoxic because of that. So again, a clinical judgment has to be in place to see which patient needs to have daily sedation vacation and which need not be having. As a rule of thumb, you know, there's no guidelines to back it up, but let's say somebody is needing more than 60% oxygen and is on 10 of PEEP or something like that, you don't want to wake them up. You would want the oxygen to come down to a respectable level, less than 60%, and relatively lower PEEP, like 5 or 8 of PEEP, before you want to wake them up and think about, you know, advancing the care forward. Okay, next slide, please. Now, there will be a time when you won't be able to oxygenate anybody based on these parameters that you've already set. Now, what do you do in these kind of situations? In these kind of situations, a couple of things that you try to do is, number one, use a neuromuscular blocking agent, like a paralytic, okay? I always use vecuronium as a paralytic. Start as PRN, as needed one, okay? 0.1 milligrams per kilo body weight. But the pharmacy, again, will help you with the dose of this. You don't have to memorize them, okay? If the PRN is not sufficient, you can use a continuous infusion of that. Use it for 48 hours and then reassess. Majority of the times you start using it, it will take away the patient ventilator desynchrony and help you oxygenate better, because now the ventilator is taking complete control over the breathing of the patient, and it really helps, okay? Sometimes it doesn't help. Then you start to increase the PEEP. Okay, but always, as we mentioned earlier, try to keep the PEEP less than 12, 14, you know, use your judgment based on that. Okay, always diurese. If you have a room to diurese, always diurese. There have been tons of literature to support the fact that all ARDS patients do much better if they are fluid negative slightly. So always diurese them, okay? If none of these things work, you always call for help. ECMO is used as a salvage maneuver, and the only place here that you would find somebody doing ECMO is Dr. Sidney Houellette at Baptist, who does it for respiratory issues, okay? In fact, yesterday I did talk to him about one of the patients. Right now they're very wary of taking anybody with COVID, but I think as time goes by, we'll have more patients and more need for ECMO. They may ease up their restrictions and they may be taking more of our patients. Next slide, please. Now, all of these patients you will encounter, because they will be on the ventilator for quite some time, you will encounter several different issues related to different aspects of critical care management. One of the ones very commonly seen is hemodynamic compromise, okay? Now, starts getting hypotensive. What do? Of course, the first thing is judicious administration of fluids, okay? And always use crystalloids like normal saline or Ringer's lactate, okay? And the goal is to give a loading dose of 30 mils per kilogram body weight as a bolus. Not necessarily people try and stop it at 30 mils per kilogram body weight, not necessarily that people cannot need more fluids, but then you have to reassess the patient and see if their requirements are more, and you can give more boluses if the need be. Okay, now you have adequately fluid resuscitated, the blood pressures still continue to be low. When I say the blood pressure is low, what do we mean by that is a mean arterial pressure less than 65. Absolute numbers of the systolic and diastolic do not mean much. What matters is the mean arterial pressure. You want to be greater than 65, okay? Now what do you do in these circumstances? You start a pressor. Now what are the pressors that you would like to use? You'd like to use, as a first line, norepinephrine, second line, vasopressin, and third line, epinephrine. That's what has been advocated in the most recent the sepsis and septic shock guidelines. Avoid dopamine as much as possible. Plenty of arrhythmias can occur with that. Again, you will have another complication to deal with the dopamine. We don't want more complications, okay? Always evaluate for organ dysfunction. How do you evaluate for organ dysfunction, okay? Very, very simple. Look at the urine output. As long as somebody is making 30 mils an hour of urine, you're doing a fantastic job, okay? Whatever be the blood pressure, doesn't matter. Urine output is good, that's a good thing. Lactic acid, follow serial lactic acids. Lactic acid, the trend is going down, good job. LFTs, okay? and always try and get echocardiograms to know objective assessment of how the LV function is doing, and do we need to get our specialist involved. Very important that we get our nephrologists, our cardiologists, our specialists pertaining to different organ systems as early as possible. You know, we should not be waiting for things to go out of hand. You're seeing a renal failure in these patients, always get them involved. Creatinine 1.7, even if it is just 1.7, they are making urine, still please get the nephrologist involved, because at least you'll have a specialist manage a particular aspect of that. You'll have less things to worry about, okay? Troponin's going up. There's always a chance. We have several comorbidities that these patients have, okay? Let the cardiologist be on board, okay? Let them do what they want to do, okay? Very important. Now, you've done a very good job. Everything's improving. When do I extubate my patients, okay? So there are certain goals that these patients have to meet before you think about extubating them. One of the goals that I look at usually is the oxygenation goal. Is the oxygenation adequate? As in, is the FiO2 down to like 40 to 50%, and if the PEEP to 5 or 8? If you have achieved that, think about extubation. Faster extubation, better outcomes, okay? Hemodynamic goals. Is the person off the vasopressors, or is the pressure requirement trending down? If all of these things are happening, then that means you have achieved the hemodynamic goal and you should proceed forward. Airway goals. Does the patient have cough and a gag reflex? Is the mental status improving? If all of these things are a yes, always think about an extubation, okay? Now, how do you extubate? Without going into details of the different ways and means of thinking about extubation, the best thing always to do is talk to RT. They know all about it, okay? They will help you. They will put the person on a spontaneous breathing trial and let you know if that person is good enough to be extubated or not. You don't have to fret much with all of these things. Now, we've talked all about how to manage these patients in the ICU, but what about the absolute medications? How do I treat these patients effectively? Now, there is no strong data on any of these medications, okay? All of the data that we have is very anecdotal. We don't even know the exact dosing on the medication that we are supposed to use, okay? So what I've tried to do is Taylor James in pharmacy, very good resource. She's very knowledgeable, and she'll help you the maximum to try and arrange whatever medications, because a lot of them are experimental medications that you need, okay? The first and the most data that I have seen is on remdesivir, okay? So remdesivir is an old medication actually, and it's manufactured by Gilead, but the only way they approve you is only on compassionate grounds. Taylor knows all about it, okay? She will do that. We have tried then, actually one of our patients got approved. We are not able to get the medication over here, okay? She's trying her best to get it, but she knows all about the paperwork and everything that needs to be done, okay? Hydroxychloroquine, with or without azithromycin, as I mentioned in the previous slide, easy to use. We have it. Always start with these medications, okay? There is one thing that a lot of people have not used. I have used, and it has worked very well, I think, in the couple of patients that I have treated, okay? One of the patients actually has improved a lot based on that. I've tried and used vitamin C, okay? And very high dose vitamin C, the dose that we use for the septic shock, okay? Very simple, vitamin C, not much of side effects. You know, we are not overburdening anything on them. And if something works, we try and use it, okay? So I've used that, and it has worked out very well. We do have some ritonavir and lopinavir, okay? If all of the above doesn't work, then you, as a salvage maneuver, you can try and use this ritonavir and lopinavir, and it has worked well in these situations. Lastly, there is another medication. I have not put it out on the board, but I have used it only once, and that particular one, there is a concept called as interleukin storm, a cytokine storm in these patients, okay? Suddenly, after 3 to 4 days of the patients being intubated, suddenly you would see that their white cell count starts to jump up, procalcitonin starts to jump up, all of these things happening, and it's probably related to the cytokine storm concept. And what studies have shown us is there's a lot of load of interleukin-6. We do have a monoclonal antibody for the interleukin-6. It's called tocilizumab. We do have it in our pharmacy. We can use it. but be cognizant of all the problems and risks that are associated with using monoclonal antibodies. The one that I used, she started getting very hypertensive, so I had to stop it. But the experiences may be very different in other patients. So those are the ones that we have to use. And that's all that I had for everybody.
Thank you.
If you have any questions or anything.
Is there any role for IVIG?
Actually, it has been shown to, most of the studies have shown that you're not supposed to use it, the IVIG.
Okay.
Recently, FDA actually approved, just today I saw, these was the fresh frozen plasma from coronavirus recovered patients. But then, as we say, I mean, all of these things are evolving. We'll get more data. Right now, we don't have much idea about these things. Right now, the whole focus is on supportive care. We got to support these patients and let the body take care of itself over time.
Hydroxychloroquine, can we start them on the patients who are suspecting COVID or ones that tested?
Completely agreed. On suspected COVID patients, you can start, but it all depends on how strongly you are suspecting. Right now, if we are even thinking about somebody having COVID, you're starting them. But if I don't see any lung infiltrates on anybody, then I don't want to start the hydroxychloroquine on them.
Are there any particular precautions, with the extubation, because that's, again, a good chance for droplet spread and that sort of thing. Is there any particular additional precautions other than, of course, the PPE that we're all in that we can use for the patient to reduce the chance of droplet spread during the extubation process itself?
So during the extubation process, it's a very closed circuit. Okay, so as long as the tube stays inside, we do not run the risk of aerosol generation in that.
Right.
What matters is immediate post-extubation, what do we do? Okay, we actually ask the patient to cough during those times.
Precisely.
So that is the time when the RTs have been told that the moment they are thinking of the tube is going to come out, they put in a mask on the patient right away, so that even if they have a cough reflex, because you'll cough because of that, and you prevent aerosol generation.
Shroud or something like that to kind of encapsulate it during that cough when we're pulling the tube.
We don't have anything right now with us available as such. We just have the PPEs that we are using, but I think judicious caution is very, very important in these situations.
Hey, this is Taylor James. I'm actually on the call. I actually learned yesterday at UAMS, the one patient they extubated, they put him on a Precedex drip right before. That way, when they extubated, he was sedated but could still obviously breathe on his own, and it helped limit the coughing. So that might be something we could think about.
That's a good thought. We may try doing it. Yeah.
Yeah.
That would, the highest risk that would occur to me, is the immediate exposure as you're pulling that tube and you get a spray of droplet and everyone's involved.
I agree.
Increases their exposure.
I completely agree.
I also did want to comment on the hydroxychloroquine. Yeah, the data is interesting to say the least. It's definitely worth trying right now, at least, but we do have to be judicious with our use, and that we have quite a few tablets on hand right now, but I'll tell you, we're having a hard time getting it. It's on allocation now because every hospital in the country is wanting it. And even outpatient setting, we're having to limit it as well. So we don't want to start just every single person on it. I agree with Dr. Mohammad in that if they are being tested for it, we're highly suspicious, they have lung infiltrates, that could be a good candidate, especially if they have comorbidities. But in your healthier patient who is admitted, who could probably even go home, maybe not those patients, but definitely call, you can definitely call me for help with that as well, but because we're trying to be as judicious as we can be, but also want to take care of the patient as well, because the data is just, I don't know, it all makes me uncomfortable, but I'm willing to try it on patients right now, but anyway, we don't want to just run out because we may not be able to get much more once we are out of it.
I agree. I completely agree. We don't have a whole lot of very robust data, but as I said, patients who are suspected or who have active lung infiltrates, respiratory failure, they should be the first one to get this hydroxychloroquine. Relatively healthier patients, of course, we can definitely avoid it.
And the azithromycin thing, I agree with the plus or minus aspect of it. I'm not, the data is terrible for it. I don't know if it in combination with hydroxychloroquine does anything. If we think they have a community-acquired pneumonia, atypical component, sure, azithro is awesome for that. We know in severe CAT patients, azithromycin is really a great option for them. But I really recommend getting an EKG initially, and then maybe every other day or so. I know we're trying to limit PPE and limit procedures and things, but I do worry about QTC prolongation when you add azithro and hydroxychloroquine. The couple of patients we've had it on so far, their QTCs have been okay, but that obviously could be a terrible drug adverse effect. So definitely get an EKG at least a couple of times while they're on that therapy.
I agree.
If the patient is on telemetry, I think that will show up on telemetry.
Of course.
Rather than exposing the test to going to do EKG every other day, those side effects, they are not very common in practice.
Yeah.
I mean, theoretically, we read them in textbook, but we don't see them a lot.
Most of the time, we are already treating these patients for a pneumonia, for a bacterial pneumonia. So what I have seen is they're already on azithromycin, okay, most of the time for the 5 days, 3 days, whatever you want to use them. The hydroxychloroquine is added on top of it, okay. So if they're already on it, I don't think so we need to take away the azithromycin. But if you ask me whether we should start azithromycin plus hydroxychloroquine both in these patients, I don't think so. We know that as to what works. I would just go with hydroxychloroquine for now, okay.
Yeah, I agree with that.
If they're already on azithromycin, we continue. But
Sure.
to
So
start,
we don't want to run out of Zithro either. So Zithro is starting to run lower too from the drug manufacturer. I mean, we have plenty, but we do not want to run out of that either. So,
The report that I've read, particularly in Seattle, they've tried some of the other antiviral medicines, and I haven't seen any convincing data one way or the other. Do you have anything that you noted on that, Dr. Mohammad?
Not if we are thinking about something like a flu.
Like
Okay.
Sofluza and
Yeah. If you're
recommended.
if you are thinking about actual flu, then you use it. But I have not seen any data to support the use of these medications
this is particularly, trying to target COVID-19.
COVID-19. I don't think so. There is.
Use other antiviral agents in a small subset of patients. I haven't seen whether or not anyone thought that was, helpful. Was it neutral? Did it actually worsen things? That's one of the things that.
So the Society for Critical Care Medicine published their guidelines recently, like late last week, and they mentioned all of these things, what we talked about, and I did not find any mention of using any antivirals specifically targeting COVID other than the ones experimentally that have been mentioned.
right. They actually recommended against lopinavir.
Strong data to support the use of those things.
I'm going to unmute this line to see if there's any, it may give us a little bit of static, but I just wanted to see if there are any questions out there.
I have additional comment and question.
Okay, go ahead.
What's our ICU situation right now?
What is what?
ICU situation.
The ICU situation. I knew we had a clean ICU and a dirty ICU. Is that about the same, or has it changed, or?
I think, the whole concept of a clean and a dirty ICU right now is very, very blurred because the number of patients that we have been having. So right now, we only have the SICU open. We don't have the CCU that is open anymore. And we have a partition in the SICU where we keep the patients that we are not suspecting a COVID-19 in them or who have not been proven to be COVID-19 in a different place in the back of the ICU. And the front end, around about from 30 to 37, are the ones that we are keeping the patients who are actual COVID or suspected COVID patients over there.
I have a question regarding the NSAIDs, Dr. Mohammed?
Regarding what, the NSAID? Yes, please, go ahead.
Is there a data that confirms the need to avoid the NSAID, as the World Health Organization last week issued that there is no data to support stopping NSAIDs or avoiding them in suspected COVID patients? And the other question is there a need to stop ACE inhibitors, ARBs, in suspected patients with COVID?
So to answer your first question about NSAIDs, the CDC has recommended avoiding. They don't have like an absolute criteria not to use NSAIDs, but they recommend to avoid NSAIDs for pain control or fever control in these patients. And I completely agree with that, even though if you do not have any data to see if the COVID is getting worse or not, but we have enough data that using NSAIDs in people whose hemodynamics is kind of on the edge will cause more organ dysfunction, more GI bleeding, and more complications. And that's the thing that you want to avoid as much as possible. Now, the second question about ACE inhibitors and ARBs, most of the data on that is very theoretical on that because of the way this virus binds to those receptors in the lung. I have not found any data to say that, if somebody is already on an ACE inhibitor or an ARB, to stop them because of the suspicion for the COVID causing worse outcomes in them. I think if we stop the ACE inhibitors and ARBs, there is a chance that we may actually get them worse for the reasons they were already on the ACE inhibitors for. If there is a heart failure person who's on ACE inhibitors or a diabetic on ACE inhibitors, we actually can cause more harm to them than good by stopping them as of now.
Yeah, I agree. Everything I've read has said do not stop them if they're on it for heart failure or hypertension. There's not data to say that's beneficial, probably more harmful. I agree.
Okay, thank you.
Thank you, Dr. Mohammad.
Thank you very much.
Great.
Did I get compromised to make sure that the residents that weren't able to?
How you doing, sir?
Go good.